Section 15 of Gray's Anatomy, Part 5. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 5, by Henry Gray. The Esophagus. The esophagus, or gullet, is a muscular canal about 23 to 25 centimeters long, extending from the pharynx to the stomach. It begins in the neck at the lower border of the cricoid cartilage, opposite the sixth cervical vertebra, descends along the front of the vertebral column through the superior and posterior mediastina, passes through the diaphragm, and entering the abdomen, ends at the cardiac orifice of the stomach, opposite the 11th thoracic vertebra. The general direction of the esophagus is vertical, but it presents two slight curves in its course. At its commencement it is placed in the middle line, but it inclines to the left side as far as the root of the neck, gradually passes to the middle line again at the level of the fifth thoracic vertebra, and finally deviates to the left as it passes forward to the esophageal hiatus in the diaphragm. The esophagus also presents antero-posterior flexures corresponding to the curvatures of the cervical and thoracic portions of the vertebral column. It is the narrowest part of the digestive tube, and is most contracted at its commencement and at the point where it passes through the diaphragm. Relations. The cervical portion of the esophagus is in relation in front with the trachea and at the lower part of the neck where it projects to the left side with the thyroid gland. Behind, it rests upon the vertebral column and longus colli muscles. On either side, it is in relation with the common carotid artery, especially the left as it inclines to that side, and parts of the lobes of the thyroid gland. The recurrent nerves ascend between it and the trachea. To its left side is the thoracic duct. The thoracic portion of the esophagus is at first situated in the superior mediastinum between the trachea and the vertebral column, a little to the left of the median line. It then passes behind and to the right of the aortic arch, and descends in the posterior mediastinum along the right side of the descending aorta, then runs in front and a little to the left of the aorta, and enters the abdomen through the diaphragm at the level of the 10th thoracic vertebra. Just before it perforates the diaphragm, it presents a distinct dilation. It is in relation in front with the trachea, the left bronchus, the pericardium, and the diaphragm. Behind, it rests upon the vertebral column, the longus colli muscles, the right aortic intercostal arteries, the thoracic duct, and the hemiazygos veins, and below, near the diaphragm, upon the front of the aorta. On its left side, in the superior mediastinum, are the terminal part of the aortic arch, the left subclavian artery, the thoracic duct, and the left pleura, while running upward in the angle between it and the trachea is the left recurrent nerve. Below, it is in relation with the descending thoracic aorta. On its right side are the right pleura and the azygos vein, which it overlaps. Below the roots of the lungs, the vagi descend in close contact with it, the right nerve passing down behind and the left nerve in front of it, the two nerves uniting to form a plexus around the tube. In the lower part of the posterior mediastinum, the thoracic duct lies to the right side of the esophagus. Higher up, it is placed behind it, and crossing about the level of the 4th thoracic vertebra is continued upward on its left side. The abdominal portion of the esophagus lies in the esophageal groove on the posterior surface of the left lobe of the liver. It measures about 1.25 centimeters in length, and only its front and left aspects are covered by peritoneum. It is somewhat conical with its base applied to the upper orifice of the stomach, and is known as the antrum cardiacum. Structure. The esophagus has 4 coats, an external or fibrous, a muscular, a submucous or areolar, and an internal or mucous coat. The muscular coat, tunica muscularis, is composed of 2 planes of considerable thickness, an external of longitudinal and an internal of circular fibers. The longitudinal fibers are arranged at the commencement of the tube in 3 fasciculi, one in front, which is attached to the vertical ridge on the posterior surface of the lamina of the cricoid cartilage, and one at either side, which is continuous with the muscular fibers of the pharynx. As they descend, they blend together, and form a uniform layer, which covers the outer surface of the tube. Accessory slips of muscular fibers pass between the esophagus and the left pleura. where the latter covers the thoracic aorta, or the root of the left bronchus, or the back of the pericardium. The circular fibers are continuous above with the constrictor phalanges inferior. Their direction is transverse at the upper and lower parts of the tube, but oblique in the intermediate part. The muscular fibers in the upper part of the esophagus are of a red color and consist chiefly of the striped variety, but below they consist for the most part of involuntary fibers. The areolar or submucous coat, tela submucosa, connects loosely the mucous and muscular coats. It contains blood vessels, nerves, and mucous glands. The mucous coat, tunica mucosa, is thick, of a reddish color above and pale below. It is disposed in longitudinal folds, which disappear on distension of the tube. Its surface is studded with minute papillae, and it is covered throughout with a thick layer of stratified squamous epithelium. Beneath the mucous membrane, between it and the areolar coat, is a layer of longitudinally arranged, non-striped muscular fibers. This is the muscularis mucosae. At the commencement of the esophagus it is absent, or only represented by a few scattered bundles. Lower down it forms a considerable stratum. The esophageal glands, glandulae esophagi, are small compound racemose glands of the mucous type. They are lodged in the submucous tissue, and each opens upon the surface by a long excretory duct. Vessels and nerves. The arteries supplying the esophagus are derived from the inferior thyroid branch of the thyrocervical trunk, from the descending thoracic aorta, from the left gastric branch of the celiac artery, and from the left inferior phrenic of the abdominal aorta. They have for the most part a longitudinal direction. The nerves are derived from the vagi and from the sympathetic trunks. They form a plexus, in which are groups of ganglion cells, between the two layers of the muscular coats, and also a second plexus in the submucous tissue. End of section 15.
Of Gray's Anatomy, Part 5. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Anne Boulay. Anatomy of the Human Body, Part 5, by Henry Gray. The Abdomen, Part 1. The abdomen is the largest cavity in the body. It is of an oval shape, the extremities of the oval being directed upward and downward. The upper extremity is formed by the diaphragm, which extends as a dome over the abdomen, so that the cavity extends high into the bony thorax, reaching on the right side, in the mammary line, to the upper border of the fifth rib. On the left side it falls below this level by 2.5 centimeters. The lower extremity is formed by the structures which clothe the inner surface of the bony pelvis, principally the levator ani and the coccygeus on either side. These muscles are sometimes termed the diaphragm of the pelvis. The cavity is wider above than below, and measures more in the vertical than in the transverse diameter. In order to facilitate description, it is artificially divided into two parts: an upper and larger part, the abdomen proper, and the lower and smaller part, the pelvis. These two cavities are not separated from each other, but the limit between them is marked by the superior aperture of the lesser pelvis. The abdomen proper differs from the other great cavities of the body in being bounded for the most part by muscles and fascia, so that it can vary in capacity and shape according to the condition of the viscera which it contains. But, in addition to this, the abdomen varies in form and extent with age and sex. In the adult male, with moderate distension of the viscera, it is oval in shape, but at the same time flattened from before backward. In the adult female, with a fully developed pelvis, it is ovoid with the narrower pole upward, and in young children it is also ovoid, but with the narrower pole downward. Boundaries. It is bounded in front and at the sides by the abdominal muscles and the iliacus muscles, behind by the vertebral column and the psoas and quadratus laborum muscles, above by the diaphragm, below by the plane of the superior aperture of the lesser pelvis. The muscles forming the boundaries of the cavity are lined upon their inner surfaces by a layer of fascia. The abdomen contains the greater part of the digestive tube. Some of the accessory organs to digestion, viz., the liver and pancreas, the spleen, the kidneys, and the suprarenal glands. Most of these structures, as well as the wall of the cavity in which they are contained, are more or less covered by an extensive and complicated serous membrane, the peritoneum. The apertures in the walls of the abdomen. The apertures in the walls of the abdomen, for the transmission of structures to and from it, are in front, the umbilical in the fetus, for the transmission of the umbilical vessels, the allantois and vitelline duct; above, the vena caval opening, for transmission of the inferior vena cava, the aortic hiatus, for the passage of the aorta, azygos vein, and thoracic duct, and the esophageal hiatus, for the esophagus and vagi. Below, there are two apertures on either side, one for the passage of the femoral vessels and the lumbo-inguinal nerve, and the other for the transmission of the spermatic cord in the male and the round ligament of the uterus in the female. Regions. For convenience of description of the viscera, as well as of reference to the morbid conditions of the contained parts, the abdomen is artificially divided into 9 regions by imaginary planes, 2 horizontal and 2 sagittal, passing through the cavity, the edges of the planes being indicated by lines drawn on the surface of the body. Of the horizontal planes, the upper or transpyloric is indicated by a line encircling the body at the level of a point midway between the jugular notch and the symphysis pubis; the lower by a line carried around the trunk at the level of a point midway between the transpyloric and the symphysis pubis. The latter is practically the intertubular plane of Cunningham, who pointed out that its level corresponds with the prominent and easily defined tubercle on the iliac crest about 5 cm behind the anterior superior iliac spine. By means of these imaginary planes the abdomen is divided into 3 zones, which are named from above downward, the subcostal, the umbilical, and hypogastric zones. Each of these is further subdivided into 3 regions by the 2 sagittal planes, which are indicated on the surface by lines drawn vertically through points halfway between the anterior superior iliac spines and the symphysis pubis. The middle region of the upper zone is called the epigastric, and the 2 lateral regions, the right and left hypochondriac. The central region of the middle zone is the umbilical, and the 2 lateral regions, the right and left lumbar. The middle region of the lower zone is the hypogastric or pubic region, and the lateral regions are the right and left iliac or inguinal. The pelvis is the portion of the abdominal cavity which lies below and behind a plane passing through the promontory of the sacrum, lineae terminalis of the hip bones, and the pubic crests. It is bounded behind by the sacrum, cocci, piriformis, and the sacrospinous and sacrotuberous ligaments, in front and laterally by the pubis and ischia and obturatores internii. Above, it communicates with the abdomen proper. Below, it is closed by the levatorus ani and the coccygeae and the urogenital diaphragm. The pelvis contains the urinary bladder, the sigmoid colon and rectum, a few coils of the small intestine, and some of the generative organs. When the anterior abdominal wall is removed, the viscera are partly exposed as follows. Above and to the right side is the liver, situated chiefly under the shelter of the right ribs and their cartilages, but extending across the middle line and reaching for some distance below the level of the xiphoid process. To the left of the liver is the stomach, from the lower border of which an apron-like fold of the peritoneum, the greater omentum, descends for a varying distance, and obscures, to a greater or lesser extent, the other viscera. Below it, however, some of the coils of the small intestine can generally be seen, while in the right and left iliac regions respectively, the cecum and the iliac colon are partly exposed. The bladder occupies the anterior part of the pelvis, and if distended, will project above the symphysis pubis. The rectum lies in the concavity of the sacrum, but is usually obscured by the coils of the small intestine. The sigmoid colon lies between the rectum and the bladder. When the stomach is followed from left to right, it is seen to be continuous with the first part of the small intestine, or duodenum, the point of continuity being marked by a thickened ring which indicates the position of the pyloric valve. The duodenum passes toward the undersurface of the liver, and then, curving downward, is lost to sight. If, however, the greater omentum be thrown upward over the chest, the inferior part of the duodenum will be observed passing across the vertebral column towards the left side, where it becomes continuous with the coils of the jejunum and ilium. These measure some 6 meters in length, and if followed downward, the ilium will be seen to end in the right iliac fossa by opening into the cecum, the commencement of the large intestine. From the cecum the large intestine takes an arched course, passing at first upward on the right side, then across the middle line, and downward on the left side, and forming respectively the ascending, transverse, and descending parts of the colon. In the pelvis it assumes the form of a loop, the sigmoid colon, and ends in the rectum. The spleen lies behind the stomach in the left hypochondriac region, and may be in part exposed by pulling the stomach over toward the right side. The glistening appearance of the deep surface of the abdominal wall and of the surface of the exposed viscera is due to the fact that the former is lined, and the latter are more or less completely covered, by a serous membrane, the peritoneum. The peritoneum, tunica serosa. The peritoneum is the largest serous membrane in the body, and consists, in the male, of a closed sac, part of which is applied against the abdominal parietes, while the remainder is reflected over the contained viscera. In the female, the peritoneum is not a closed sac, since the free ends of the uterine tubes open directly into the peritoneal cavity. The part which lines the parietes is named the parietal portion of the peritoneum. That which is reflected over the contained viscera constitutes the visceral portion of the peritoneum. The free surface of the membrane is smooth, covered by a layer of fattened mesothelium, and lubricated by a small quantity of serous fluid. Hence the viscera can slide freely against the wall of the cavity or upon one another with the least possible amount of friction. The attached surface is rough, being connected to the viscera and inner surface of the parietes by means of areolar tissue, termed the subserous areolar tissue. The parietal portion is loosely connected with the facial lining of the abdomen and pelvis, but is more closely adherent to the undersurface of the diaphragm, and also in the middle line of the abdomen. The space between the parietal and visceral layers of the peritoneum is named the peritoneal cavity. But under normal conditions this cavity is merely a potential one, since the parietal and visceral layers are in contact. The peritoneal cavity gives off a large diverticulum, the omental bursa, which is situated behind the stomach and adjoining structures. The neck of communication between the cavity and the bursa is termed the epipleutic foramen, foramen of Winslow. Formerly the main portion of the cavity was described as the greater, and the omental bursa the lesser sac. The peritoneum differs from the other serous membranes of the body in presenting a much more complex arrangement, and one that can be clearly understood only by following the changes which take place in the digestive tube during its development. To trace the membrane from one viscus to another, and from the viscera to the parietes, it is necessary to follow its continuity in the vertical and horizontal directions, and it will be found simpler to describe the main portion of the cavity and the omental bursa separately. Vertical disposition of the main peritoneal cavity, greater sac. It is convenient to trace this from the back of the abdominal wall at the level of the umbilicus. In following the peritoneum upward from this level, it is seen to be reflected around a fibrous cord, the ligamentum teres, obliterated umbilical vein, which reaches from the umbilicus to the undersurface of the liver. This reflection forms a somewhat triangular fold, the falciform ligament of the liver, attaching the upper and anterior surfaces of the liver to the diaphragm and abdominal wall. With the exception of the line of attachment of this ligament, the peritoneum covers the whole of the undersurface of the anterior part of the diaphragm, and is continued from it onto the upper surface of the right lobe of the liver as the superior layer of the coronary ligament, and onto the upper surface of the left lobe as the superior layer of the left triangular ligament of the liver. Covering the upper and anterior surfaces of the liver, it is continued around its sharp margin onto the under surface, where it presents the following relations. A. It covers the under surface of the right lobe and is reflected from the back part of this onto the right suprarenal gland and the upper extremity of the right kidney, forming in this situation the inferior layer of the coronary ligament. A special fold, the hepatorenal ligament, is frequently present between the inferior surface of the liver and the front of the kidney. From the kidney it is carried downward to the duodenum and the right colic flexure and medial ward in front of the inferior vena cava, where it is continuous with the posterior wall of the omental bursa. Between the two layers of the coronary ligament there is a large triangular surface of the liver devoid of peritoneal covering. This is named the bare area of the liver, and is attached to the diaphragm by areolar tissue. Toward the right margin of the liver the two layers of the coronary ligament gradually approach each other, and ultimately fuse to form a small triangular fold connecting the right lobe of the liver to the diaphragm, and named the right triangular ligament of the liver. The apex of the triangular bare area corresponds with the point of meeting of the two layers of the coronary ligament, its base with the fossa for the inferior vena cava. B. It covers the lower surface of the quadrat lobe, the under and lateral surfaces of the gallbladder, and the under surface and posterior border of the left lobe. It is then reflected from the upper surface of the left lobe to the diaphragm as the inferior layer of the left triangular ligament, and from the porta of the liver and the fossa for the ductus venosus to the lesser curvature of the stomach, and the first 2.5 centimeters of the duodenum as the anterior layer of the hepatogastric and the hepatoduodenal ligaments, which together constitute the lesser omentum. If this layer of the lesser omentum be followed to the right, it will be found to turn around the hepatic artery, bile duct, and portal vein, and become continuous with the anterior wall of the omental bursa, forming a free folded edge of the peritoneum. Traced downward, it covers the antero-superior surface of the stomach and the commencement of the duodenum, and is carried down into a large free fold, known as the gastrocolic ligament or greater omentum. Reaching the free margin of this fold, it is reflected upward to cover the under and posterior surfaces of the transverse colon, and thence to the posterior abdominal wall as the inferior layer of the transverse mesocolon. It reaches the abdominal wall at the head and anterior border of the pancreas, is then carried down over the lower part of the head and over the inferior surface of the pancreas on the superior mesenteric vessels, and thence to the small intestine as the anterior layer of the mesentery. It encircles the intestine, and subsequently may be traced as the posterior layer of the mesentery, upward and backward to the abdominal wall. From this it sweeps down over the aorta into the pelvis, where it invests the sigmoid colon, its reduplication forming the sigmoid mesocolon. Leaving first the sides and then the front of the rectum, it is reflected on to the seminal vesicles and the fundus of the urinary bladder and, after covering the upper surface of this viscus, is carried along the medial and lateral umbilical ligaments onto the back of the abdominal wall to the level from which a start was made. Between the rectum and the bladder it forms, in the male, a pouch, the rectovesical excavation, the bottom of which is slightly below the level of the upper ends of the vesiculae seminales, i.e., about 7.5 centimeters from the orifice of the anus. When the bladder is distended, the peritoneum is carried up with the expanded viscus so that a considerable part of the anterior surface of the latter lies directly against the abdominal wall, without the intervention of the peritoneal membrane, pre-vesical space of Retzius. In the female, the peritoneum is reflected from the rectum over the posterior vaginal fornix to the cervix and body of the uterus, forming the rectouterine excavation, pouch of Douglas. It is continued over the intestinal surface and fundus of the uterus on its vesical surface, which it covers as far as the junction of the body and cervix uteri, and then to the bladder, forming here a second, but shallower pouch, the vesicouterine excavation. It is also reflected from the sides of the uterus to the lateral walls of the pelvis as two expanded folds, the broad ligaments of the uterus, in the free margin of each of which is the uterine tube. Vertical disposition of the omental bursa, lesser peritoneal sac. A start may be made in this case on the posterior abdominal wall at the anterior border of the pancreas. From this region, the peritoneum may be followed upward over the pancreas onto the inferior surface of the diaphragm, and thence onto the caudate lobe and the caudate process of the liver to the fossa from the ductus venosus and the porta of the liver. Traced to the right, it is continuous over the inferior vena cava with the posterior wall of the main cavity. From the liver it is carried downward to the lesser curvature of the stomach and the commencement of the duodenum as the posterior layer of the lesser omentum, and is continuous on the right around the hepatic artery, bile duct, and portal vein, with the anterior layer of this omentum. The posterior layer of the lesser omentum is carried down as a covering for the posterior inferior surfaces of the stomach and the commencement of the duodenum, and is continued downward as the deep layer of the gastrocolic ligament or greater omentum. From the free margin of this fold it is reflected upward on itself to the anterior and superior surfaces of the transverse colon, and thence as the superior layer of the transverse mesocolon to the anterior border of the pancreas, the level from which a start was made. It will be seen that the loop formed by the wall of the omental bursa below the transverse colon follows, and is closely applied to, the deep surface of that formed by the peritoneum of the main cavity, and that the greater omentum or large fold of the peritoneum which hangs in front of the small intestine therefore consists of 4 layers, 2 anterior and 2 posterior, separated by the potential cavity of the omental bursa. End of section 16. Gray's Anatomy, Part 5. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit Librivox.org. Recording by Anne Boulay. Anatomy of the Human Body, Part 5, by Henry Gray. The Abdomen, Part 2. Horizontal disposition of the peritoneum. Below the transverse colon the arrangement is simple, as it includes only the main cavity. Above the level of the transverse colon it is more complicated on account of the existence of the omental bursa. Below the transverse colon it may be considered in the 2 regions, viz., in the pelvis and in the abdomen proper. In the pelvis. The peritoneum here follows closely the surfaces of the pelvic viscera and the inequalities of the pelvic walls, and presents important differences in the 2 sexes. A. In the male, it encircles the sigmoid colon, from which it is reflected to the posterior wall of the pelvis as a fold, the sigmoid mesocolon. It then leaves the sides, and finally, the front of the rectum, and is continued on to the upper ends of the seminal vesicles and the bladder. On either side of the rectum it forms a fossa, the pararectal fossa, which varies in size with the distension of the rectum. In front of the rectum, the peritoneum forms the rectovesical excavation, which is limited laterally by the peritoneal folds extending from the sides of the bladder to the rectum and the sacrum. These folds are known from their position as the rectovesical or sacrogenital folds. The peritoneum of the anterior pelvic wall covers the superior surface of the bladder, and on either side of this viscus forms a depression, termed the paravesical fossa, which is limited laterally by the fold of peritoneum covering the ductus deferens. The size of this fossa is dependent on the state of distension of the bladder. When the bladder is empty, a variable fold of peritoneum, the plica vesicalis transversa, divides the fossa into 2 portions. On the peritoneum between the paravesical and pararectal fossae, the only elevations are those produced by the ureters and the hypogastric vessels. B. In the female, pararectal and paravesical fossae similar to those in the male are present. The lateral limit of the paravesical fossa is the peritoneum investing the round ligament of the uterus. The rectovesical excavation is, however, divided by the uterus and vagina into a small anterior vesicouterine and a large, deep posterior rectouterine excavation. The sacrogenital folds form the margins of the latter, and are continued on to the back of the uterus to form a transverse fold, the torus uterinus. The broad ligaments extend from the sides of the uterus to the lateral walls of the pelvis. They contain in their free margins the uterine tubes, and in their posterior layers the ovaries. Below, the broad ligaments are continuous with the peritoneum on the lateral walls of the pelvis. On the lateral pelvic wall, behind the attachment of the broad ligament, in the angle between the elevations produced by the diverging hypogastric and external iliac vessels, is a slight fossa, the ovarian fossa, in which the ovary normally lies. In the lower abdomen, starting with the linea alba, below the level of the transverse colon, and tracing the continuity of the peritoneum in a horizontal direction to the right, the membrane covers the inner surface of the abdominal wall almost as far as the lateral border of the quadratus lumborum. It encloses the cecum and the vermiform process, and is reflected over the sides and front of the ascending colon. It may then be traced over the duodenum, sosus major, and inferior vena cava toward the middle line, whence it passes along the mesenteric vessels to invest the small intestine, and back again to the large vessels in front of the vertebral column, forming the mesentery, between the layers of which are contained the mesenteric blood vessels, lacteals, and glands. It is then continued over the left sosus. It covers the sides and front of the descending colon, and, reaching the abdominal wall, is carried on it to the middle line. The upper abdomen. Above the transverse colon, the omental bursa is superadded to the general sac, and the communication of the two cavities with one another through the epiploic foramen can be demonstrated. A. Main cavity. Commencing on the posterior abdominal wall at the inferior vena cava, the peritoneum may be followed to the right over the front of the suprarenal gland and the upper part of the right kidney onto the anterolateral abdominal wall. From the middle line of the anterior wall, a backwardly directed fold encircles the obliterated umbilical vein and forms the falciform ligament of the liver. Continuing to the left, the peritoneum lines the anterolateral abdominal wall and covers the lateral part of the front of the left kidney, and is reflected to the posterior border of the hilus of the spleen as the posterior layer of the phrenicolenal ligament. It can then be traced around the surface of the spleen to the front of the hilus, and thence to the cardiac end of the greater curvature of the stomach as the anterior layer of the gastroilienal ligament. It covers the antero-superior surfaces of the stomach and commencement of the duodenum, and extends up from the lesser curvature of the stomach to the liver as the anterior layer of the lesser omentum. B. Omental bursa. Bursa omentalis. Lesser peritoneal sac. On the posterior abdominal wall, the peritoneum of the general cavity is continuous with that of the omental bursa in front of the inferior vena cava. Starting from here, the bursa may be traced across the aorta and over the medial part of the front of the left kidney and diaphragm to the hilus of the spleen as the anterior layer of the phrenicolenal ligament. From the spleen it is reflected to the stomach as the posterior layer of the gastrosplenic ligament. It covers the postero-inferior surfaces of the stomach and commencement of the duodenum, and extends upward to the liver as the posterior layer of the lesser omentum. The right margin of this layer is continuous around the hepatic artery, bile duct, and portal vein, with the wall of the general cavity. The epiploic foramen, foramen epiploicum, foramen of Winslow, is the passage of communication between the general cavity and the omental bursa. It is bounded in front by the free border of the lesser omentum, with the common bile duct, hepatic artery, and portal vein between its two layers, behind by the peritoneum covering the inferior vena cava, above by the peritoneum on the caudate process of the liver, and below by the peritoneum covering the commencement of the duodenum and the hepatic artery, the latter passing forward below the foramen before ascending between the two layers of the lesser omentum. The boundaries of the omental bursa will now be evident. It is bounded in front, from above downward, by the caudate lobe of the liver, the lesser omentum, the stomach, and the anterior two layers of the greater omentum. Behind, it is limited, from below upward, by the two posterior layers of the greater omentum, the transverse colon, and the ascending layer of the transverse mesocolon, the upper surface of the pancreas, the left suprarenal gland, and the upper end of the left kidney. To the right of the esophageal opening of the stomach, it is formed by that part of the diaphragm which supports the caudate lobe of the liver. Laterally, the bursa extends from the epiploic foramen to the spleen, where it is limited by the phrenicolienal and gastrolienal ligaments. The omental bursa, therefore, consists of a series of pouches or recesses to which the following terms are applied. 1. The vestibule, a narrow channel continued from the epiploic foramen over the head of the pancreas to the gastropancreatic fold. This fold extends from the omental turbosity of the pancreas to the right side of the fundus of the stomach, and contains the left gastric artery and coronary vein. 2. The superior omental recess, between the caudate lobe of the liver and the diaphragm. 3. The lienal recess, between the spleen and the stomach. 4. The inferior omental recess, which comprises the remainder of the bursa. In the fetus, the bursa reaches as low as the free margin of the greater omentum, but in the adult its vertical extent is usually more limited owing to adhesions between the layers of the omentum. During a considerable part of fetal life, the transverse colon is suspended from the posterior abdominal wall by a mesentery of its own, the two posterior layers of the greater omentum passing at this stage in front of the colon. This condition occasionally persists throughout life, but as a rule adhesion occurs between the mesentery of the transverse colon and the posterior layer of the greater omentum, with the result that the colon appears to receive its peritoneal covering by the splitting of the two posterior layers of the latter fold. In the adult, the omental bursa intervenes between the stomach and the structures on which that viscus lies, and performs therefore the functions of a serous bursa for the stomach. Numerous peritoneal folds extend between the various organs or connect them to the parietes. They serve to hold the viscera in position and, at the same time, enclose the vessels and nerves proceeding to them. They are grouped under the three headings of ligaments, omenta, and mesenteries. The ligaments will be described with their respective organs. There are two omenta, the lesser and the greater. The lesser omentum, omentum minus, small omentum, gastrohepatic omentum, is the duplicature which extends to the liver from the lesser curvature of the stomach and the commencement of the duodenum. It is extremely thin, and is continuous with the two layers of peritoneum which cover respectively the antero-superior and posterior-inferior surfaces of the stomach and first part of the duodenum. When these two layers reach the lesser curvature of the stomach and the upper border of the duodenum, they join together and ascend as a double fold to the porta of the liver. To the left of the porta, the fold is attached to the bottom of the fossa for the ductus venosus, along which it is carried to the diaphragm, where the two layers separate to embrace the end of the esophagus. At the right border of the omentum, the two layers are continuous, and form a free margin which constitutes the anterior boundary of the epiploic foramen. The portion of the lesser omentum extending between the liver and stomach is termed the hypogastric ligament, while that between the liver and the duodenum is the hepatoduodenal ligament. Between the two layers of the lesser omentum, close to the right free margin, are the hepatic artery, the common bile duct, the portal vein, lymphatics, and the hepatic plexus of nerves, all these structures being enclosed in the fibrous capsule, Glisson's capsule. Between the layers of the lesser omentum, where they are attached to the stomach, run the right and left gastric vessels. The greater omentum, omentum majus, great omentum, gastrocolic omentum, is the largest peritoneal fold. It consists of a double sheet of peritoneum, folded on itself so that it is made up of 4 layers. The 2 layers which descend from the stomach and commencement of the duodenum pass in front of the small intestines, sometimes as low down as the pelvis. They then turn upon themselves, and descend again as far as the transverse colon, where they separate and enclose that part of the intestine. These individual layers may be easily demonstrated in the young subject, but in the adult they are more or less inseparably blended. The left border of the greater omentum is continuous with the gastrolienal ligament. Its right border extends as far as the commencement of the duodenum. The greater omentum is usually thin, presents a cribiform appearance, and usually contains some adipose tissue, which in fat people accumulates in considerable quantity. Between its two anterior layers, a short distance from the greater curvature of the stomach, is the anastomosis between the right and left gastroepiplotic vessels. The mesenteries are the mesentery proper, the transverse mesocolon, and the sigmoid mesocolon. In addition to these, there are sometimes present an ascending and a descending mesocolon. The mesentery proper, mesenterium, is the broad fan-like fold of peritoneum which connects the convolutions of the jejunum and ilium with the posterior wall of the abdomen. Its root, the part connected with the structures in front of the vertebral column, is narrow, about 15 centimeters long, and is directed obliquely from the duodenojejunal flexure at the left side of the second lumbar vertebra to the right sacroiliac articulation. Its intestinal border is about 6 meters long, and here the two layers separate to enclose the intestine, and form its peritoneal coat. It is narrow above, but widens rapidly to about 20 centimeters, and is thrown into various plates or folds. It suspends the small intestine, and contains between its layers the intestinal branches of the superior mesenteric artery, with their accompanying veins and plexuses of nerves, the lacteal vessels, and mesenteric lymph glands. The transverse mesocolon, mesocolon transversus, is a broad fold which connects the transverse colon to the posterior wall of the abdomen. It is continuous with the two posterior layers of the greater omentum, which, after separating to surround the transverse colon, join behind it and are continued backward to the vertebral column, where they diverge in front of the anterior border of the pancreas. This fold contains between its layers the vessels which supply the transverse colon. The sigmoid mesocolon, mesocolon sigmoideum, is the fold of peritoneum which retains the sigmoid colon in connection with the pelvic wall. Its line of attachment forms a V-shaped curve, the apex of the curve being placed about the point of division of the left common iliac artery. The curve being on the medial side of the left sosus major, and runs upward and backward to the apex, from which it bends sharply downward, and ends in the medial plane at the level of the third sacral vertebra. The sigmoid and superior hemorrhoidal vessels run between the two layers of this fold. In most cases, the peritoneum covers only the front and sides of the ascending and descending parts of the colon. Sometimes, however, these are surrounded by the serous membrane and attached to the posterior abdominal wall by an ascending and a descending mesocolon respectively. A fold of peritoneum, the phrenicocolic ligament, is continued from the left colic flexure to the diaphragm opposite the 10th and 11th ribs. It passes below and serves to support the spleen, and therefore has received the name of susteniculum lienus. The appendices epicloacae are small pouches of the peritoneum filled with fat and situated along the colon and upper part of the rectum. They are chiefly appended to the transverse and sigmoid parts of the colon. Peritoneal recesses or fossae. Retroperitoneal fossae. In certain parts of the abdominal cavity there are recesses of peritoneum forming cul-de-sacs or pouches, which are of surgical interest in connection with the possibility of the occurrence of retroperitoneal herniae. The largest of these is the omental bursa, already described, but several others, of smaller size, require mention, and may be divided into three groups, viz., duodenal, cecal, and intersigmoid. Duodenal fossae, three are fairly constant, viz. A. The inferior duodenal fossa, present in from 70 to 75% of cases, is situated opposite the third lumbar vertebra on the left side of the ascending portion of the duodenum. Its opening is directed upward, and is bounded by a thin sharp fold of peritoneum with a concave margin, called the duodenomesocolic fold. The tip of the index finger introduced into the fossa under the fold passes some little distance behind the ascending portion of the duodenum. B. The superior duodenal fossa, present in from 40 to 50% of cases, often coexists with the inferior one, and its orifice looks downward. It lies on the left of the ascending portion of the duodenum, in front of the second lumbar vertebra, and behind a sickle-shaped form of peritoneum, the duodenal jejunal fold, and has a depth of about 2 centimeters. C. The duodenal jejunal fossa exists in from 15 to 20% of cases, but has never yet been found in conjunction with the other forms of duodenal fossae. It can be seen by pulling the jejunum downward and to the right, after the transverse colon has been pulled upward. It is bounded above by the pancreas, to the right by the aorta, and to the left by the kidney. Beneath is the left renal vein. It has a depth of about 2 to 3 centimeters, and its orifice, directed downward and to the right, is nearly circular and will admit the tip of the little finger. Cecal fossae, pericecal folds or fossae. There are 3 principal pouches or recesses in the neighborhood of the cecum. A. The superior iliocecal fossa is formed by a fold of peritoneum arching over the branch of the ileocolic artery which supplies the ileocolic junction. The fossa is a narrow chink situated between the mesentery of the small intestine, the ilium, and the small portion of the cecum behind. B. The inferior iliocecal fossa is situated behind the angle of the junction of the ilium and cecum. It is formed by the iliocecal fold of peritoneum, bloodless fold of Treves, the upper border of which is fixed to the ilium, opposite its mesenteric attachment, while the lower border, passing over the iliocecal junction, joins the mesenterial of the vermiform process, and sometimes the process itself. Between this fold and the mesenterial of the vermiform process is the inferior iliocecal fossa. It is bounded above by the posterior surface of the ilium and the mesentery, in front and below by the iliocecal fold, and behind by the upper part of the mesenterial of the vermiform process. C. The cecal fossa is situated immediately behind the cecum, which has to be raised to bring it into view. It varies much in size and extent. In some cases it is sufficiently large to admit the index finger, and extends upward behind the ascending colon in the direction of the kidney. In others it is merely a shallow depression. It is bounded on the right by the cecal fold, which is attached by one edge of the abdominal wall from the lower border of the kidney to the iliac fossa, and by the other to the posterolateral aspect of the colon. In some instances, additional fossae, the retrocecal fossae, are present. The intersigmoid fossa, recessus intersigmoideus, is constant in the fetus and during infancy, but disappears in a certain percentage of cases as age advances. Upon drawing the sigmoid colon upward, the left surface of the sigmoid mesocolon is exposed, and on it will be seen a funnel-shaped recess of the peritoneum, lying on the external iliac vessels, in the interspace between the sosus and iliacus muscles. This is the orifice leading to the intersigmoid fossa, which lies behind the sigmoid mesocolon, and in front of the parietal peritoneum. The fossa varies in size. In some instances it is a mere dimple, whereas in others it will admit the whole of the index finger. End of section 17.
Section 18 of Gray's Anatomy, Part 5. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 5, by Henry Gray. The Stomach. Ventriculus. Gaster. The stomach is the most dilated part of the digestive tube, and is situated between the end of the esophagus and the beginning of the small intestine. It lies in the epigastric, umbilical, and left hypochondriac regions of the abdomen, and occupies a recess bounded by the upper abdominal viscera, and completed in front and on the left side by the anterior abdominal wall and the diaphragm. The shape and position of the stomach are so greatly modified by changes within itself and in the surrounding viscera that no one form can be described as typical. The chief modifications are determined by 1. The amount of the stomach contents, 2. The stage which the digestive process has reached, 3. The degree of development of the gastric musculature, and 4. The condition of the adjacent intestines. It is, however, possible, by comparing a series of stomachs, to determine certain markings more or less common to all. The stomach presents two openings, two borders or curvatures, and two surfaces. Openings. The opening by which the esophagus communicates with the stomach is known as the cardiac orifice, and is situated on the left of the middle line at the level of the 10th thoracic vertebra. The short abdominal portion of the esophagus, antrum cardiacum, is conical in shape and curved sharply to the left, the base of the cone being continuous with the cardiac orifice of the stomach. The right margin of the esophagus is continuous with the lesser curvature of the stomach, while the left margin joins the greater curvature at an acute angle, termed the incisura cardiaca. The pyloric orifice communicates with the duodenum, and its position is usually indicated on the surface of the stomach by a circular groove, the duodenal pyloric constriction. This orifice lies to the right of the middle line at the level of the upper border of the first lumbar vertebra. Curvatures. The lesser curvature, curvatura ventriculi minor, extending between the cardiac and pyloric orifices, forms the right or posterior border of the stomach. It descends as a continuation of the right margin of the esophagus in front of the fibers of the right crus of the diaphragm, and then, turning to the right, it crosses the first lumbar vertebra and ends at the pylorus. Nearer its pyloric than its cardiac end is a well-marked notch, the incisura angularis, which varies somewhat in position with the state of distension of the viscus. It serves to separate the stomach into a right and left portion. The lesser curvature gives attachment to the two layers of the hepatogastric ligament, and between these two layers are the left gastric artery and the right gastric branch of the hepatic artery. The greater curvature, curvatura ventriculi major, is directed mainly forward, and is 4 or 5 times as long as the lesser curvature. Starting from the cardiac orifice at the incisura cardiaca, it forms an arch backward, upward, and to the left. The highest point of the convexity is on a level with the 6th left costal cartilage. From this level it may be followed downward and forward with a slight convexity to the left, as low as the cartilage of the 9th rib. It then turns to the right, to the end of the pylorus. Directly opposite the incisura angularis of the lesser curvature, the greater curvature presents a dilation, which is the left extremity of the pyloric part. This dilation is limited on the right by a slight groove, the sulcus intermedius, which is about 2.5 centimeters from the duodenal pyloric constriction. The portion between the sulcus intermedius and the duodenal pyloric constriction is termed the pyloric antrum. At its commencement, the greater curvature is covered by peritoneum, continuous with that covering the front of the organ. The left part of the curvature gives attachment to the gastrolienal ligament, while to its anterior portion are attached the two layers of the greater omentum, separated from each other by the gastroepiploic vessels. Surfaces. When the stomach is in the contracted condition, its surfaces are directed upward and downward respectively, but when the viscus is distended, they are directed forward and backward. They may therefore be described as antero-superior and postero-inferior. Antero-superior surface. The left half of this surface is in contact with the diaphragm, which separates it from the base of the left lung, the pericardium, and the 7th, 8th, and 9th ribs, and intercostal spaces of the left side. The right half is in relation with the left and quadrate lobes of the liver, and with the anterior abdominal wall. When the stomach is empty, the transverse colon may lie on the front part of this surface. The whole surface is covered by peritoneum. The postero-inferior surface is in relation with the diaphragm, the spleen, the left suprarenal gland, the upper part of the front of the left kidney, the anterior surface of the pancreas, the left colic flexure, and the upper layer of the transverse mesocolon. These structures form a shallow bed, the stomach bed, on which the viscus rests. The transverse mesocolon separates the stomach from the duodenal jejunal flexure and the small intestine. The postero-inferior surface is covered by peritoneum, except over a small area close to the cardiac orifice. This area is limited by the lines of attachment of the gastrophrenic ligament, and lies in apposition with the diaphragm, and frequently with the upper portion of the left suprarenal gland. Component parts of the stomach. A plane passing through the incisura angularis on the lesser curvature and the left limit of the opposed dilation on the greater curvature divides the stomach into a left portion or body and a right or pyloric portion. The left portion of the body is known as the fundus, and is marked off from the remainder of the body by a plane passing horizontally through the cardiac orifice. The pyloric portion is divided by a plane through the sulcus intermedius at right angles to the long axis of this portion. The part to the right of this plane is the pyloric antrum. If the stomach be examined during the process of digestion, it will be found divided by a muscular constriction into a large dilated left portion and a narrow contracted tubular right portion. The constriction is in the body of the stomach and does not follow any of the anatomical landmarks. Indeed, it shifts gradually toward the left as digestion progresses. That is, more of the body is gradually absorbed into the tubular part. Position of the stomach. The position of the stomach varies with the posture, with the amount of the stomach contents, and with the condition of the intestines on which it rests. In the erect posture, the empty stomach is somewhat J-shaped. The part above the cardiac orifice is usually distended with gas. The pylorus descends to the level of the second lumbar vertebra, and the most dependent part of the stomach is at the level of the umbilicus. Variation in the amount of its contents affects mainly the cardiac portion, the pyloric portion remaining in a more or less contracted condition during the process of digestion. As the stomach fills, it tends to expand forward and downward in the direction of least resistance. But when this is interfered with by a distended condition of the colon or intestines, the fundus presses upward on the liver and diaphragm and gives rise to the feelings of oppression and palpitation complained of in such cases. Hiss and Cunningham have shown by hardening the viscera in situ that the contracted stomach has a sickle shape, the fundus looking directly backward. The surfaces are directed upward and downward, the upper surface having, however, a gradual downward slope to the right. The greater curvature is in front and at a slightly higher level than the lesser. The position of the full stomach depends, as already indicated, on the state of the intestines. When these are empty, the fundus expands vertically and so forward. The pylorus is displaced toward the right, and the whole organ assumes an oblique position, so that its surfaces are directed more forward and backward. The lowest part of the stomach is at the pyloric vestibule, which reaches into the region of the umbilicus. Where the intestines interfere with the downward expansion of the fundus, the stomach retains the horizontal position which is characteristic of the contracted viscus. Examination of the stomach during life by X-rays has confirmed these findings, and has demonstrated that, in the erect posture, the full stomach usually presents a hook-like appearance, the long axis of the clinical fundus being directed downward, medialward, and forward toward the umbilicus, while the pyloric portion curves upward to the duodenal pyloric junction. Interior of the stomach. When examined after death, the stomach is usually fixed at some temporary stage of the digestive process. A common form is shown in Fig. 1050. If the viscus be laid open by a section through the plane of its two curvatures, it is seen to consist of two segments: A large globular portion to the left, and B, a narrow tubular part on the right. These correspond to the clinical subdivisions of fundus and pyloric portions already described, and are separated by a constriction which indents the body in greater curvature, but does not involve the lesser curvature. To the left of the cardiac orifice is the incisura cardiaca. The projection of this notch into the cavity of the stomach increases as the organ distends, and has been supposed to act as a valve, preventing regurgitation into the esophagus. In the pyloric portion are seen A, the elevation corresponding to the incisura angularis, and B, the circular projection of the duodenal pyloric constriction, which forms the pyloric valve. The separation of the pyloric antrum from the rest of the pyloric part is scarcely indicated. The pyloric valve, valvula pylori, is formed by a reduplication of the mucous membrane of the stomach, covering a muscular ring composed of a thickened portion of the circular layer of the muscular coat. Some of the deeper longitudinal fibers turn in and interlace with the circular fibers of the valve. Structure. The wall of the stomach consists of four coats: serous, muscular, areolar, and mucous, together with vessels and nerves. The serous coat, tunica serosa, is derived from the peritoneum and covers the entire surface of the organ, excepting along the greater and lesser curvatures at the points of the attachment of the greater and lesser omenta. Here the two layers of peritoneum leave a small triangular space, along which the nutrient vessels and nerves pass. On the posterior surface of the stomach, close to the cardiac orifice, There is also a small area uncovered by peritoneum where the organ is in contact with the undersurface of the diaphragm. The muscular coat, tunica muscularis, is situated immediately beneath the serous covering, with which it is closely connected. It consists of 3 sets of smooth muscle fibers, longitudinal, circular, and oblique. The longitudinal fibers, stratum longitudinale, are the most superficial and are arranged in 2 sets. The first set consists of fibers continuous with the longitudinal fibers of the esophagus. They radiate in a stellate manner from the cardiac orifice and are practically all lost before the pyloric portion is reached. The second set commences on the body of the stomach and passes to the right, its fibers becoming more thickly distributed as they approach the pylorus. Some of the more superficial fibers of this set pass on to the duodenum, but the deeper fibers dip inward and interlace with the circular fibers of the pyloric valve. The circular fibers, stratum circulare, form a uniform layer over the whole extent of the stomach beneath the longitudinal fibers. At the pylorus they are most abundant, and are aggregated into a circular ring, which projects into the lumen and forms, with the fold of mucous membrane covering its surface, the pyloric valve. They are continuous with the circular fibers of the esophagus, but are sharply marked off from the circular fibers of the duodenum. The oblique fibers, fibri obliqui, internal to the circular layer, are limited chiefly to the cardiac end of the stomach, where they are disposed as a thick uniform layer covering both surfaces, some passing obliquely from left to right, others from right to left, around the cardiac end. The areolar or submucous coat, tela submucosa, consists of a loose areolar tissue connecting the mucous and muscular layers. The mucous membrane, tunica mucosa, is thick and its surface is smooth, soft, and velvety. In the fresh state it is of pinkish tinge at the pyloric end and of a red or reddish-brown color over the rest of its surface. In infancy it is of a brighter hue, the vascular redness being more marked. It is thin at the cardiac extremity, but thicker toward the pylorus. During the contracted state of the organ it is thrown into numerous plates or rugae, which for the most part have a longitudinal direction, and are most marked toward the pyloric end of the stomach and along the greater curvature. These folds are entirely obliterated when the organ becomes distended. Structure of the mucous membrane. When examined with a lens, the inner surface of the mucous membrane presents a peculiar honeycomb appearance from being covered with small shallow depressions or alveoli of a polygonal or hexagonal form, which vary from 0.12 to 0.25 millimeters in diameter. These are the ducts of the gastric glands, and at the bottom of each may be seen one or more minute orifices, the openings of the gland tubes. The surface of the mucous membrane is covered by a single layer of columnar epithelium with occasional goblet cells. This epithelium commences very abruptly at the cardiac orifice, where there is a sudden transition from the stratified epithelium of the esophagus. The epithelial lining of the gland ducts is of the same character and is continuous with the general epithelial lining of the stomach. The gastric glands. The gastric glands are of 3 kinds: A. Pyloric, B. Cardiac, and C. Fundus or oxyntic glands. They are tubular in character and are formed of a delicate basement membrane consisting of flattened, transparent endothelial cells lined by epithelium. The pyloric glands are found in the pyloric portion of the stomach. They consist of 2 or 3 short closed tubes opening into a common duct or mouth. These tubes are wavy and are about 1/2 the length of the duct. The duct is lined by columnar cells, continuous with the epithelium lining the surface of the mucous membrane of the stomach, the tubes by shorter and more cubical cell, which are finely granular. The cardiac glands, few in number, occur close to the cardiac orifice. They are of 2 kinds: 1. Simple tubular glands resembling those of the pyloric end of the stomach, but with short ducts. 2. Compound racemose glands resembling the duodenal glands. The fundus glands are found in the body and fundus of the stomach. They are simple tubes, 2 or more of which open into a single duct. The duct, however, in these glands is shorter than in the pyloric variety, sometimes not amounting to more than 1/6 of the whole length of the gland. It is lined throughout by columnar epithelium. The gland tubes are straight and parallel to each other. At the point where they open into the duct, which is termed the neck, the epithelium alters, and consists of short columnar or polyhedral granular cells, which almost fill the tube. so that the lumen becomes suddenly constricted and is continued down as a very fine channel. They are known as the chief or central cells of the glands. Between these cells and the basement membrane, larger oval cells which stain deeply with eosin are found. These cells are studded throughout the tube at intervals, giving it a beaded or varicose appearance. These are known as the parietal or oxyntic cells, and they are connected with the lumen by fine channels which run into their substance. Between the glands, the mucous membrane consists of a connective tissue framework with lymphoid tissue. In places, this later tissue, especially in early life, is collected into little masses which to a certain extent resemble the solitary nodules of the intestine and are termed the lenticular glands of the stomach. They are not, however, so distinctly circumscribed as the solitary nodules. Beneath the mucous membrane, and between it and the submucous coat, is a thin stratum of involuntary muscular fiber, muscularis mucosae, which in some parts consists only of a single longitudinal layer, in others of 2 layers, an inner circular and an outer longitudinal. Vessels and nerves. The arteries supplying the stomach are the left gastric, the right gastric, and the right gastroepiploic branches of the hepatic, the left gastroepiploic and short gastric branches of the lyinal. They supply the muscular coat, ramify in the submucous coat, and are finally distributed to the mucous membrane. The arrangement of the vessels in the mucous membrane is somewhat peculiar. The arteries break up at the base of the gastric tubules into a plexus of fine capillaries which run upward between the tubules, anastomosing with each other and ending in a plexus of larger capillaries which surround the mouths of the tubes, and also form hexagonal meshes around the ducts. From these the veins arise, and pursue a straight course downward between the tubules to the submucous tissue. They end either in the lyinal and superior mesenteric veins or directly in the portal vein. The lymphatics are numerous. They consist of a superficial and a deep set, and pass to the lymph glands found along the 2 curvatures of the organ. The nerves are the terminal branches of the right and left vagi, the former being distributed upon the back, and the latter upon the front part of the organ. A great number of branches from the celiac plexus of the sympathetic are also distributed to it. Nerve plexuses are found in the submucous coat and between the layers of the muscular coat as in the intestine. From these plexuses, fibrils are distributed to the muscular tissue and the mucous membrane. End of section 18.
Of Gray's Anatomy, Part 5. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Mark Rocher. Anatomy of the Human Body, Part 5, by Henry Gray. 2G. The Small Intestine. Intestinum tenue. The small intestine is a convoluted tube extending from the pylorus to the colic valve, where it ends in the large intestine. It is about 7 meters long. Footnote. Treves states that in 100 cases the average length of the small intestine in the adult male was 22 feet 6 inches, and in the adult female 23 feet 4 inches, but that it varies very much, the extremes in the male being 31 feet 10 inches and 15 feet 6 inches. He states that in the adult the length of the bowel is independent of age, height, and weight. End footnote. And gradually diminishes in size from its commencement to its termination. It is contained in the central and lower part of the abdominal cavity, and is surrounded above and at the sides by the large intestine. A portion of it extends below the superior aperture of the pelvis and lies in front of the rectum. It is in relation, in front, with the greater omentum and abdominal parietes, and is connected to the vertebral column by a fold of peritoneum, the mesentery. The small intestine is divisible into 3 portions, the duodenum, the jejunum, and the ilium. The duodenum has received its name from being about equal in length to the breadth of 12 fingers, 25 centimeters. It is the shortest, the widest, and the most fixed part of the small intestine, and has no mesentery, being only partially covered by peritoneum. Its course presents a remarkable curve, somewhat of the shape of an imperfect circle, so that its termination is not far removed from its starting point. In the adult, the course of the duodenum is as follows. Commencing at the pylorus, it passes backward, upward, and to the right, beneath the quadrate lobe of the liver to the neck of the gallbladder, varying slightly in direction according to the degree of distension of the stomach. It then takes a sharp curve and descends along the right margin of the head of the pancreas, for a variable distance, generally to the level of the upper border of the body of the fourth lumbar vertebra. It now takes a second bend and passes from right to left across the vertebral column, having a slight inclination upward, and on the left side of the vertebral column it ascends for about 2.5 centimeters, and then ends opposite the second lumbar vertebra in the jejunum. As it unites with the jejunum, it turns abruptly forward, forming the duodeno-jejunal flexure. From the above description, it will be seen that the duodenum may be divided into 4 portions: superior, descending, horizontal, and ascending. Relations. The superior portion, pars superior, first portion, is about 5 centimeters long. Beginning at the pylorus, it ends at the neck of the gallbladder. It is the most movable of the 4 portions. It is almost completely covered by peritoneum, but a small part of its posterior surface, near the neck of the gallbladder and the inferior vena cava, is uncovered. The upper border of its first half has the hepatoduodenal ligament attached to it, while to the lower border of the same segment the greater omentum is connected. It is in such close relation with the gallbladder that it is usually found to be stained by bile after death, especially on its anterior surface. It is in relation above and in front with the quadrate lobe of the liver and the gallbladder, behind with the gastroduodenal artery, the common bile duct, and the portal vein, and below and behind with the head and neck of the pancreas. The descending portion, pars descendens, second portion, is from 7 to 10 centimeters long, and extends from the neck of the gallbladder on a level with the first lumbar vertebra along the right side of the vertebral column as low as the upper border of the body of the fourth lumbar vertebra. It is crossed in its middle third by the transverse colon, the posterior surface of which is uncovered by peritoneum and is connected to the duodenum by a small quantity of connective tissue. The supra- and infracolic portions are covered in front by peritoneum, the infracolic part by the right leaf of the mesentery. Posteriorly, the descending portion of the duodenum is not covered by peritoneum. The descending portion is in relation, in front, from above downward, with the duodenal impression on the right lobe of the liver, the transverse colon, and the small intestine. Behind, it has a variable relation to the front of the right kidney, in the neighborhood of the ilium, and is connected to it by loose areolar tissue. The renal vessels, the inferior vena cava, and the psoas below are also behind it. At its medial side is the head of the pancreas and the common bile duct. To its lateral side is the right colic flexure. The common bile duct and the pancreatic duct together perforate the medial side of this portion of the intestine obliquely, some 7 to 10 centimeters below the pylorus. The accessory pancreatic duct sometimes pierces it about 2 centimeters above and slightly in front of these. The horizontal portion, pars horizontalis, third or pre-aortic or transverse portion, is from 5 to 7.5 centimeters long. It begins at the right side of the upper border of the fourth lumbar vertebra and passes from right to left, with a slight inclination upward, in front of the great vessels and crura of the diaphragm, and ends in the ascending portion in front of the abdominal aorta. It is crossed by the superior mesenteric vessels and the mesentery. Its front surface is covered by peritoneum, except near the middle line, where it is crossed by the superior mesenteric vessels. Its posterior surface is uncovered by peritoneum, except towards its left extremity, where the posterior layer of the mesentery may sometimes be found covering it to a variable extent. This surface rests upon the right crus of the diaphragm, the inferior vena cava, and the aorta. The upper surface is in relation with the head of the pancreas. The ascending portion, pars ascendens, fourth portion, of the duodenum is about 2.5 centimeters long. It ascends on the left side of the aorta as far as the level of the upper border of the second lumbar vertebra, where it turns abruptly forward to become the jejunum, forming the duodenojejunal flexure. It lies in front of the left psoas major and left renal vessels, and is covered in front and partly at the sides by peritoneum continuous with the left portion of the mesentery. The superior part of the duodenum, as stated above, is somewhat movable, but the rest is practically fixed, and is bound down to neighboring viscera and the posterior abdominal wall by the peritoneum. In addition to this, the ascending part of the duodenum and the duodenojejunal flexure are fixed by a structure to which the name of musculus suspensorius duodeni has been given. This structure commences in the connective tissue around the celiac artery and left crus of the diaphragm, and passes downward to be inserted into the superior border of the duodenojejunal curve and a part of the ascending duodenum, and from this it is continued into the mesentery. It possesses, according to Treitz, plain muscular fibers mixed with the fibrous tissue of which it is principally made up. It is of little importance as a muscle, but acts as a suspensory ligament. Vessels and nerves. The arteries supplying the duodenum are the right gastric and superior pancreatic duodenal branches of the hepatic, and the inferior pancreatic duodenal branch of the superior mesenteric. The veins end in the lienal and superior mesenteric. The nerves are derived from the celiac plexus. Jejunum and ilium. The remainder of the small intestine from the end of the duodenum is named jejunum and ilium, the former term being given to the upper 2/5 and the latter to the lower 3/5. There is no morphological line of distinction between the two, and the division is arbitrary. But at the same time, the character of the intestine gradually undergoes a change from the commencement of the jejunum to the end of the ilium, so that a portion of the bowel taken from these two situations would present characteristic and marked differences. These are briefly as follows. The jejunum, intestinum jejunum, is wider, its diameter being about 4 centimeters, and is thicker, more vascular, and of a deeper color than the ilium, so that a given length weighs more. The circular folds, valvulae conniventes, of its mucous membrane are large and thickly set, and its villi are larger than in the ilium. The aggregated lymph nodules are almost absent in the upper part of the jejunum, and in the lower part are less frequently found than in the ilium, and are smaller and tend to assume a circular form. By grasping the jejunum between the finger and thumb, the circular folds can be felt through the walls of the gut, these being absent in the lower part of the ilium. It is possible in this way to distinguish the upper from the lower part of the small intestine. The ilium, intestinum ilium, is narrow, its diameter being 3.75 centimeters, and its coats thinner and less vascular than those of the jejunum. It possesses but few circular folds, and they are small and disappear entirely toward its lower end, but aggregated lymph nodules, Peyer's patches, are larger and more numerous. The jejunum for the most part occupies the umbilical and left iliac regions, while the ilium occupies chiefly the umbilical, hypogastric, right iliac, and pelvic regions. The terminal part of the ilium usually lies in the pelvis, from which it ascends over the right psoas and right iliac vessels. It ends in the right iliac fossa by opening into the medial side of the commencement of the large intestine. The jejunum and ilium are attached to the posterior abdominal wall by an extensive fold of peritoneum, the mesentery, which allows the freest motion, so that each coil can accommodate itself to changes in form and position. The mesentery is fan-shaped, its posterior border, or root, about 15 centimeters long, is attached to the posterior abdominal wall from the left side of the body of the second lumbar vertebra to the right sacroiliac articulation, crossing successively the horizontal part of the duodenum, the aorta, the inferior vena cava, the ureter, and the right psoas muscle. Its breadth between its vertebral and intestinal borders averages about 20 centimeters, and is greater in the middle than at its upper and lower ends. According to Lockwood, it tends to increase in breadth as age advances. Between the two layers of which it is composed are contained blood vessels, nerves, lacteals, and lymph glands, together with a variable amount of fat. Meckel's diverticulum, Diverticulum ilii. This consists of a pouch which projects from the lower part of the ilium in about 2% of subjects. Its average position is about 1 meter above the colic valve, and its average length about 5 centimeters. Its caliber is generally similar to that of the ilium, and its blind extremity may be free or may be connected with the abdominal wall or some other portion of the intestine by a fibrous band. It represents the remains of the proximal part of the vitelline duct, the duct of communication between the yolk sac and the primitive digestive tube in early fetal life. End of section 19. Recording by Marc Rocher. Section 20 of Gray's Anatomy, Part 5. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Marc Rocher. 2G. The small intestine. Structure. The wall of the small intestine is composed of 4 coats: serous, muscular, areolar, and mucous. The serous coat, tunica serosa, is derived from the peritoneum. The superior portion of the duodenum is almost completely surrounded by this membrane near its pyloric end, but is only covered in front and at the other extremity. The descending portion is covered by it in front, except where it is carried off by the transverse colon, and the inferior portion lies behind the peritoneum, which passes over it without being closely incorporated with the other coats of this part of the intestine, and is separated from it in and near the middle line by the superior mesenteric vessels. The rest of the small intestine is surrounded by the peritoneum, excepting along its attached or mesenteric border. Here a space is left for the vessels and nerves to pass to the gut. The muscular coat, tunica muscularis, consists of 2 layers of unstriped fibers, an external longitudinal and an internal circular layer. The longitudinal fibers are thinly scattered over the surface of the intestine, and are more distinct along its free border. The circular fibers form a thick, uniform layer, and are composed of plain muscle cells of considerable length. The muscular coat is thicker at the upper than at the lower part of the small intestine. The areolar or submucous coat, tela submucosa, connects together the mucous and muscular layers. It consists of loose filamentous areolar tissue containing blood vessels, lymphatics, and nerves. It is the strongest layer of the intestine. The mucous membrane, tunica mucosa, is thick and highly vascular at the upper part of the small intestine, but somewhat paler and thinner below. It consists of the following structures. Next, the areolar or submucous coat is a double layer of unstriped muscular fibers, outer longitudinal and inner circular. The muscularis mucosae internal to this is a quantity of retiform tissue, enclosing in its meshes lymph corpuscles, and in this the blood vessels and nerves ramify. Lastly, a basement membrane supporting a single layer of epithelial cells, which throughout the intestine are columnar in character. The cells are granular in appearance, and each possesses a clear, oval nucleus. At their superficial or unattached ends, they present a distinct layer of highly refracting material, marked by vertical striae, the striated border. The mucous membrane presents for examination the following structures contained within it or belonging to it: circular folds, villi, intestinal glands, duodenal glands, solitary lymphatic nodules, aggregated lymphatic nodules. The circular folds, plicae circulares, Kerkringi, valvuli conniventes, valves of Kerkring, are large valvular flaps projecting into the lumen of the bowel. They are composed of reduplications of the mucous membrane, the 2 layers of the fold being bound together by submucous tissue. Unlike the folds in the stomach, they are permanent, and are not obliterated when the intestine is distended. The majority extend transversely around the cylinder of the intestine for about 1/2 or 2/3 of its circumference. but some form complete circles, and others have a spiral direction. The latter usually extend a little more than once around the bowel, but occasionally 2 or 3 times. The larger folds are about 8 millimeters in depth at their broadest part, but the greater number are of smaller size. The larger and smaller folds alternate with each other. They are not found at the commencement of the duodenum, but begin to appear about 2.5 or 5 centimeters beyond the pylorus. In the lower part of the descending portion, below the point where the bile and pancreatic ducts enter the intestine, they are very large and closely approximated. In the horizontal and ascending portions of the duodenum and upper half of the jejunum, they are large and numerous, but from this point down to the middle of the ilium they diminish considerably in size. In the lower part of the ilium they almost entirely disappear. Hence the comparative thinness of this portion of the intestine as compared with the duodenum and jejunum. The circular folds retard the passage of the food along the intestines, and afford an increased surface for absorption. The intestinal villi, villi intestinales, are highly vascular processes, projecting from the mucous membrane of the small intestine throughout its whole extent, and giving to its surface a velvety appearance. They are largest and most numerous in the duodenum and jejunum, and become fewer and smaller in the ilium. Structure of the villi. The essential parts of a villus are the lacteal vessel, the blood vessels, the epithelium, the basement membrane, and the muscular tissue of the mucosa, all being supported and held together by retiform lymphoid tissue. The lacteals are in some cases double, and in some animals multiple, but usually there is a single vessel. Situated in the axis of the villus, each commences by dilated cecal extremities near to, but not quite at, the summit of the villus. The walls are composed of a single layer of endothelial cells. The muscular fibers are derived from the muscularis mucosae, and are arranged in longitudinal bundles around the lacteal vessel, extending from the base to the summit of the villus, and giving off, laterally, individual muscle cells, which are enclosed by the reticulum, and by it are attached to the basement membrane and to the lacteal. The blood vessels form a plexus under the basement membrane, and are enclosed in the reticular tissue. These structures are surrounded by the basement membrane, which is made up of a stratum of endothelial cells, and upon this is placed a layer of columnar epithelium, the characteristics of which have been described. The retiform tissue forms a network in the meshes of which a number of leukocytes are found. The intestinal glands, glandulae intestinales libercunae, crypts of Libercun, are found in considerable numbers over every part of the mucous membrane of the small intestine. They consist of minute tubular depressions of the mucous membrane, arranged perpendicularly to the surface, upon which they open by small circular apertures. They may be seen with the aid of a lens, their orifices appearing as minute dots scattered between the villi. Their walls are thin, consisting of a basement membrane lined by columnar epithelium, and covered on their exterior by capillary vessels. The duodenal glands, glandulae duodenales Bruneri, Brunner's glands, are limited to the duodenum, and are found in the submucous areolar tissue. They are largest and most numerous near the pylorus, forming an almost complete layer in the superior portion and upper half of the descending portions of the duodenum. They then begin to diminish in number and practically disappear at the junction of the duodenum and jejunum. They are small compound acinotubular glands consisting of a number of alveoli lined by short columnar epithelium and opening by a single duct on the inner surface of the intestine. The solitary lymphatic nodules, noduli lymphaticae solitarii, solitary glands, are found scattered throughout the mucous membrane of the small intestine, but are most numerous in the lower part of the ilium. Their free surfaces are covered with rudimentary villi, except at the summits, and each gland is surrounded by the openings of the intestinal glands. Each consists of a dense interlacing retiform tissue closely packed with lymph corpuscles, and permeated with an abundant capillary network. The interspaces of the retiform tissue are continuous with larger lymph spaces which surround the gland, through which they communicate with the lacteal system. They are situated partly in the submucous tissue, partly in the mucous membrane, where they form slight projections of its epithelial layer. The aggregated lymphatic nodules, noduli lymphaticae aggregatae, Peyer's patches, Peyer's glands, agminated follicles, tonsillae intestinales, form circular or oval patches, from 20 to 30 in number, and varying in length from 2 to 10 centimeters. They are largest and most numerous in the ilium. In the lower part of the jejunum they are small, circular, and few in number. They are occasionally seen in the duodenum. They are placed lengthwise in the intestine, and are situated in the portion of the tube most distant from the attachment of the mesentery. Each patch is formed of a group of solitary lymphatic nodules covered with mucous membrane, but the patches do not, as a rule, possess villi on their free surfaces. They are best marked in the young subject, become indistinct in middle age, and sometimes disappear altogether in advanced life. They are freely supplied with blood vessels, which form an abundant plexus around each follicle, and give off fine branches permeating the lymphoid tissue in the interior of the follicle. The lymphatic plexuses are especially abundant around these patches. Vessels and nerves. The jejunum and ilium are supplied by the superior mesenteric artery, the intestinal branches of which, having reached the attached borders of the bowel, run between the serous and muscular coats, with frequent inosculations to the free border, where they also anastomose with other branches running around the opposite surface of the gut. From these vessels numerous branches are given off, which pierce the muscular coat, supplying it and forming an intricate plexus in the submucous tissue. From this plexus minute vessels pass to the glands and villi of the mucous membrane. The veins have a similar course and arrangement to the arteries. The lymphatics of the small intestine, lacteals, are arranged in two sets, those of the mucous membrane and those of the muscular coat. The lymphatics of the villi commence in these structures in the manner described above. They form an intricate plexus in the mucous and submucous tissue, being joined by the lymphatics from the lymph spaces at the bases of the solitary nodules, and from this pass to larger vessels at the mesenteric border of the gut. The lymphatics of the muscular coat are situated to a great extent between the two layers of muscular fibers, where they form a close plexus. Throughout their course they communicate freely with the lymphatics from the mucous membrane, and empty themselves in the same manner as these into the origins of the lacteal vessels at the attached border of the gut. The nerves of the small intestine are derived from the plexuses of sympathetic nerves around the superior mesenteric artery. From this source they run to the myenteric plexus, Auerbach's plexus, of nerves and ganglia situated between the circular and longitudinal muscular fibers from which the nervous branches are distributed to the muscular coats of the intestine. From this, a secondary plexus, the plexus of the submucosa, Meissner's plexus, is derived, and is formed by branches which have perforated the circular muscular fibers. This plexus lies in the submucous coat of the intestine. It also contains ganglia from which nerve fibers pass to the muscularis mucosae and to the mucous membrane. The nerve bundles of the submucous plexus are finer than those of the myenteric plexus. End of section 20. Recording by Mark Roche, Tokyo, Japan. One of Gray's Anatomy, Part 5. This is a Librivox recording. All Librivox recordings are in the public domain. For more information, or to volunteer, please visit LibriVox.org. Recording by Mark Roche. Anatomy of the Human Body, Part 5, by Henry Gray. Chapter 2H. The Large Intestine. Intestinum crassum. The large intestine extends from the end of the ilium to the anus. It is about 1.5 meters long, being 1/5 of the whole extent of the intestinal canal. Its caliber is largest at its commencement at the cecum, and gradually diminishes as far as the rectum, where there is a dilation of considerable size just above the anal canal. It differs from the small intestine in its greater caliber, its more fixed position, its sacculated form, and in possessing certain appendages to its external coat, the appendices epiploici. Further, its longitudinal muscular fibers do not form a continuous layer around the gut, but are arranged in 3 longitudinal bands, or tinii. The large intestine, in its course, describes an arch which surrounds the convolutions of the small intestine. It commences in the right iliac region, in a dilated part, the cecum. It ascends through the right lumbar and hypochondriac regions to the under surface of the liver. It here takes a bend, the right colic flexure, to the left, and passes transversely across the abdomen on the confines of the epigastric and umbilical regions, to the left hypochondriac region. It then bends again, the left colic flexure, and descends through the left lumbar and iliac regions to the pelvis, where it forms a bend called the sigmoid flexure. From this it is continued along the posterior wall of the pelvis to the anus. The large intestine is divided into the cecum, colon, rectum, and anal canal. The cecum, intestinum cecum, the commencement of the large intestine, is the large blind pouch situated below the colic valve. Its blind end is directed downward, and its open end upward, communicating directly with the colon, of which this blind pouch appears to be the beginning, or head, and hence the old name of caput cecum coli was applied to it. Its size is variously estimated by different authors, but on an average it may be said to be 6.25 centimeters in length and 7.5 in breadth. It is situated in the right iliac fossa, above the lateral half of the inguinal ligament. It rests on the iliacus and psoas major, and usually lies in contact with the anterior abdominal wall, but the greater omentum and, if the cecum be empty, some coils of small intestine may lie in front of it. As a rule, it is entirely enveloped by peritoneum, but in a certain number of cases, 5% vary, the peritoneal covering is not complete, so that the upper part of the posterior surface is uncovered and connected to the iliac fascia by connective tissue. The cecum lies quite free in the abdominal cavity and enjoys a considerable amount of movement, so that it may become herniated down the right inguinal canal, and has occasionally been found in an inguinal hernia on the left side. The cecum varies in shape, but according to Treves, in man it may be classified under one of 4 types. In early fetal life it is short, conical, and broad at the base, with its apex turned upward and medialward toward the iliocolic junction. It then resembles the cecum of some monkeys, e.g. Mangabey monkey. As the fetus grows, the cecum increases in length more than in breadth, so that it forms a longer tube than in the primitive form, and without the broad base, but with the same inclination of the apex toward the iliocolic junction. This form is seen in other monkeys, e.g. the spider monkey. As development goes on, the lower part of the tube ceases to grow, and the upper part becomes greatly increased, so that at birth there is a narrow tube, the vermiform process, hanging from a conical projection, the cecum. This is the infantile form, and as it persists throughout life in about 2% of cases, it is regarded by Treves as the first of his 4 types of human ceca. The cecum is conical, and the appendix rises from its apex. The 3 longitudinal bands start from the appendix and are equidistant from each other. In the second type, the conical cecum has become quadrate by the growing out of a saccule on either side of the anterior longitudinal band. These saccules are of equal size, and the appendix arises from between them, instead of from the apex of a cone. This type is found in about 3% of cases. The third type is the normal type of man. Here, the 2 saccules, which in the second type were uniform, have grown at unequal rates, the right with greater rapidity than the left. In consequence of this, an apparently new apex has been formed by the growing downward of the right saccule, and the original apex, with the appendix attached, is pushed over to the left toward the ileocolic junction. The 3 longitudinal bands still start from the base of the vermiform process, but they are now no longer equidistant from each other, because the right saccule has grown between the anterior and posterolateral bands, pushing them over to the left. This type occurs in about 90% of cases. The 4th type is merely an exaggerated condition of the 3rd. The right saccule is still larger, and at the same time the left saccule has become atrophied, so that the original apex of the cecum, with the vermiform process, is close to the ileocolic junction, and the anterior band courses medialward to the same situation. This type is present in about 4% of cases. The vermiform process, or appendix, processus vermiformis, is a long, narrow, worm-shaped tube, which starts from what was originally the apex of the cecum, and may pass in one of several directions: upward behind the cecum, to the left behind the ilium and mesentery, or downward into the lesser pelvis. It varies from 2 to 20 centimeters in length, its average being about 8.3 centimeters. It is retained in position by a fold of peritoneum, mesenteriole, derived from the left leaf of the mesentery. This fold, in the majority of cases, is more or less triangular in shape, and as a rule extends along the entire length of the tube. Between its 2 layers, and close to its free margin, lies the appendicular artery. The canal of the vermiform process is small, extends through the whole length of the tube, and communicates with the cecum by an orifice which is placed below and behind the ileocecal opening. It is sometimes guarded by a semilunar valve formed by a fold of mucous membrane, but this is by no means constant. Structure. The coats of the vermiform process are the same as those of the intestine: serous, muscular, submucous, and mucous. The serous coat forms a complete investment for the tube, except along the narrow line of attachment of its mesenteriole in its proximal 2/3. The longitudinal muscular fibers do not form 3 bands, as in the greater part of the large intestine, but invest the whole organ, except at 1 or 2 points where both the longitudinal and circular fibers are deficient, so that the peritoneal and submucous coats are contiguous over small areas. The circular muscle fibers form a much thicker layer than the longitudinal fibers, and are separated from them by a small amount of connective tissue. The submucous coat is well marked, and contains a large number of masses of lymphoid tissue, which cause the mucous membrane to bulge into the lumen, and so render the latter of small size and irregular shape. The mucous membrane is lined by columnar epithelium, and resembles that of the rest of the large intestine, but the intestinal glands are fewer in number. The colic valve, valvula coli, ileocecal valve. The lower end of the ilium ends by opening into the medial and back part of the large intestine, at the point of junction of the cecum with the colon. The opening is guarded by a valve consisting of 2 segments or lips, which project into the lumen of the large intestine. If the intestine has been inflated and dried, the lips are of semilunar shape. The upper one, nearly horizontal in direction, is attached by its convex border to the line of junction of the ilium with the colon. The lower lip, which is longer and more concave, is attached to the line of junction of the ilium with the cecum. At the ends of the aperture, the 2 segments of the valve coalesce, and are continued as narrow membranous ridges around the canal for a short distance, forming the frenula of the valve. The left or anterior end of the aperture is rounded. The right or posterior is narrow and pointed. In the fresh condition, or in specimens which have been hardened in situ, the lips project as thick, cushion-like folds into the lumen of the large gut, while the opening between them may present the appearance of a slit, or may be somewhat oval in shape. Each lip of the valve is formed by a reduplication of the mucous membrane and of the circular muscular fibers of the intestine, the longitudinal fibers and peritoneum being continued uninterruptedly from the small to the large intestine. The surfaces of the valve directed toward the ilium are covered with villi, and present the characteristic structure of the mucous membrane of the small intestine, while those turned toward the large intestine are destitute of villi, and marked with the orifices of the numerous tubular glands peculiar to the mucous membrane of the large intestine. These differences in structure continue as far as the free margins of the valve. It is generally maintained that this valve prevents reflux from the cecum into the ilium, but in all probability it acts as a sphincter around the end of the ilium, and prevents the contents of the ilium from passing too quickly into the cecum. The colon is divided into 4 parts: the ascending, transverse, descending, and sigmoid. The ascending colon, colon ascendens, is smaller in caliber than the cecum, with which it is continuous. It passes upward from its commencement at the cecum, opposite the colic valve, to the under surface of the right lobe of the liver, on the right of the gallbladder, where it is lodged in a shallow depression, the colic impression. Here it bends abruptly forward and to the left, forming the right colic hepatic flexure. It is retained in contact with the posterior wall of the abdomen by the peritoneum, which covers its anterior surface and sides, its posterior surface being connected by loose areolar tissue with the iliacus, quadratus lumborum, aponeurotic origin of transversus abdominis, and with the front of the lower and lateral part of the right kidney. Sometimes the peritoneum completely invests it, and forms a distinct but narrow mesocolon. It is in relation in front with the convolutions of the ilium and the abdominal parietes. The transverse colon, colon transversum, the longest and most movable part of the colon, passes with a downward convexity from the right hypochondriac region across the abdomen, opposite the confines of the epigastric and umbilical zones, into the left hypochondriac region, where it curves sharply on itself beneath the lower end of the spleen, forming the left colic splenic flexure. In its course it describes an arch, the concavity of which is directed backward and a little upward. Toward its splenic end there is often an abrupt U-shaped curve, which may descend lower than the main curve. It is almost completely invested by peritoneum, and is connected to the inferior border of the pancreas by a large and wide duplicature of that membrane, the transverse mesocolon. It is in relation, by its upper surface, with the liver and gallbladder, the greater curvature of the stomach, and the lower end of the spleen. By its anterior surface, with the anterior layers of the greater omentum and the abdominal parietes. Its posterior surface is in relation from right to left with the descending portion of the duodenum, the head of the pancreas, and some of the convolutions of the jejunum and ilium. The left colic, or splenic flexure, is situated at the junction of the transverse and descending parts of the colon, and is in relation with the lower end of the spleen and the tail of the pancreas. The flexure is so acute that the end of the transverse colon usually lies in contact with the front of the descending colon. It lies at a higher level than, and on a plane posterior to, the right colic flexure, and is attached to the diaphragm, opposite the 10th and 11th ribs, by a peritoneal fold, named the phrenicocolic ligament, which assists in supporting the lower end of the spleen. The descending colon, colon descendens, passes downward through the left hypochondriac and lumbar regions along the lateral border of the left kidney. At the lower end of the kidney it turns medialward toward the lateral border of the psoas, and then descends, in the angle between psoas and quadratus lumborum, to the crest of the ilium, where it ends in the iliac colon. The peritoneum covers its anterior surface and sides, while its posterior surface is connected by areolar tissue with the lower and lateral part of the left kidney, the aponeurotic origin of the transversus abdominis, and the quadratus lumborum. It is smaller in caliber and more deeply placed than the ascending colon, and is more frequently covered with peritoneum on its posterior surface than the ascending colon, treves. In front of it are some coils of the small intestine. The iliac colon is situated in the left iliac fossa and is about 12 to 15 centimeters long. It begins at the level of the iliac crest, where it is continuous with the descending colon, and ends in the sigmoid colon at the superior aperture of the lesser pelvis. It curves downward and medialward in front of the iliacus and psoas, and, as a rule, is covered by peritoneum on its sides and anterior surface only. End of section 21. Recording by Mark Roche, Tokyo, Japan.